Modern healthcare operates on a highly optimized sequence. A patient presents a symptom, a clinician diagnoses a pathology, and a targeted intervention, usually a pill or procedure, is prescribed. Yet physicians routinely encounter patients whose declining health stems from entirely different sources. A patient presents with chronic headaches and severe anxiety, but the root cause is housing instability, persistent poverty, or profound social isolation. At this exact juncture, the clinical architecture hits a hard limit. The general practitioner has no pharmaceutical intervention to right away poverty and no surgical tool to excise loneliness. Primary care was historically designed to triage and manage acute biological disease. It was built for a clinically contained environment, not the complex web of non-medical needs that drive today's chronic health crises. The primary care system is forced to manage the biological symptoms of environmental conditions it is structurally unequipped to resolve. To bridge this gap between clinical medicine and social determinants, health systems are deploying a formal, integrated approach called social prescribing. Rather than offering generic lifestyle advice to get out more, social prescribing establishes a measurable architecture that connects patients directly to non-clinical community resources. Major national health authorities, including the NHS, are adopting this as a rigorous systemic referral mechanism. We are going to deconstruct the operational mechanics of this pathway, evaluate the clinical evidence proving its efficacy, and expose the systemic vulnerabilities that threaten its implementation. To address modern challenges like isolation and chronic illness, health systems have to engineer standardized, actionable pathways directly into the community ecosystem. The pathway initiates inside a standard 10-minute clinical encounter when a general practitioner identifies a complex social need aggravating a patient's health. Because the physician lacks the time and specialized knowledge to navigate local charities and support groups, the referral is routed to a specialized workforce, the link worker. Link workers translate clinical referrals into personalized care plans, building trust to move patients into the community. They apply specific navigation expertise to match unique profiles with the correct interventions, routing a patient in debt differently than a socially isolated widower. These practitioners utilize specialized professional expertise. Their role cannot be reduced to administrative routing or simply handing a patient a pamphlet of local phone numbers. The link worker is the essential human infrastructure, making social prescribing possible. Without this central node, the entire referral pathway collapses back into fragmented advice. Once the link worker establishes the care plan, patients are integrated into a varied landscape of third sector community assets that serve as the actual interventions. One major modality is green prescribing. By connecting patients with nature-based activities like conservation groups or community gardens, the pathway targets anxiety and aids in the management of long-term chronic conditions. Another pathway utilizes arts and culture prescriptions, leveraging local museums, galleries, and heritage sites directly as health resources. Initiatives like University College London's Museums on Prescription project demonstrate that cultural participation builds social identity. It fosters a sense of belonging that actively combats loneliness among isolated demographics. Localized physical activity prescriptions operate on similar mechanics. They help patients translate a physician's generic advice to exercise more into sustainable, community-supported habits like group walking or ballroom dance. These non-medical prescriptions function by substituting passive patienthood with active community participation and social integration. To validate this architecture, we have to look past the conceptual appeal and examine the empirical data. Does connecting patients to community resources generate robust clinical benefits? This chart displays a forest plot data visualization comparing standard GP care against care supplemented by social prescribing. It reveals the evidence concerning older adults, demonstrating verifiable reductions in loneliness and improvements in life satisfaction when community referral is utilized. This data is critical because isolation is a severe global public health crisis for aging populations, carrying mortality risks comparable to physical disease. Beyond aging populations, the evidence base is expanding into applications for youth and adolescent mental health. The Well-Being While Waiting study evaluated how social prescribing is utilized for children and adolescents stuck on extended waiting lists for specialist mental health services. Even while awaiting formal clinical treatment, These adolescents showed measurable improvements in resilience, pro-social behavior, and behavioral activation, resulting directly from community engagement. Rigorous, controlled studies confirm that structured social interventions generate measurable clinical improvements across the entire human lifespan. However, deploying this framework at scale exposes a major systemic friction point, threatening the entire model. The referral architecture structurally transfers clinical burden and patient demand away from the hospital and directly onto voluntary and third sector organizations. This geographic heat map compares high clinical need in red against community funding in blue. It highlights a critical flaw. Community assets are frequently underfunded and unequipped for medical-level volume. Thus, mismatch zones with extreme deprivation naturally possess the weakest infrastructure and lack funded assets. Health policy researchers offer a stark warning regarding this discrepancy. Social prescribing cannot function as a cheap substitute for adequately funded welfare, housing, and structural social services. The pathway is structurally limited by the health of the underlying community ecosystem. Clinicians cannot prescribe assets that do not exist. Addressing these vulnerabilities requires reframing social prescribing from a one-way local referral into a closed-loop system integrated with global health strategies. International health authorities, including the World Health Organization, are now driving the formalization of this model to combat the social determinants of health on a global scale. Frameworks like the SPHE model, social prescribing and health equity, are emerging to guide this integration. The SPHE model dictates that referral pathways must be deliberately co-designed with marginalized communities to actively advance health equity, ensuring the system doesn't merely provide extra options for already privileged groups. When executed correctly, the patient outcome data generated by these community interventions feeds directly back into clinical networks, creating vital population health intelligence. Social prescribing transforms isolated community interactions into actionable, systemic public health data. The systemic adoption of this architecture is driven by a strict health economics imperative, the hypothesis that formalized community support will reduce avoidable GP visits, hospital admissions, and overall clinical care costs. The current state of the economic evidence reflects a complex reality. While early results are encouraging, proving robust long-term cost-effectiveness across massive health systems remains an ongoing challenge for researchers. The model exists in a dual reality. It is highly effective at improving individual resilience, but its large-scale viability is entirely contingent on governments investing directly in local community infrastructure. The traditional biomedical sequence of diagnosis and pharmacology still cannot treat the environmental realities of isolation, poverty, and housing instability. Integrating social prescribing into primary care marks a move away from purely clinical interventions. It recognizes social connection, arts and nature, and community participation as foundational health infrastructure, moving medicine beyond pills.